For the next talk, we'll invite Dr. Pranav Chadhha from Mumbai for the next abstract presentation.
Welcome, Dr. Pranav.
Shall we share your slides? We have Dr. Pranav Chadha's slide. Dr. Pranav, you are not audible. I think you are mute. Can you unmute?
Hello, Dr. Pranav. Can you hear us, please? You need to.
Yes, I can.
Yeah.
Because I'm not able to share my screen with you.
We can see your screen now, sir. We can see
Alright.
the slides. If you can make it on a slideshow,
Now,
fantastic.
can you see it?
Oh, yes, sir.
Right?
All yours.
Alright,
Maybe
thank
a
you.
volume a little higher, sir. Otherwise, everything is set. Thank you.
Can you hear me now?
Very well, sir.
I'm nicely audible. All right. So this is an abstract that I'm supposed to present. It's the role of gefitinib, an anti-EGFR inhibitor with concurrent thoracic radiotherapy in an unresectable, locally advanced non-small cell lung cancer with EGFR mutation. It was from a West Japan oncology group, and it was published this year in May 2021 in the Journal of Thoracic Oncology. The background that around 10% of patients with locally advanced NSCLC harbor an EGFR mutation, and there is a declined benefit with an immune checkpoint inhibitor in this population. Gefitinib, an EGFR tyrosine kinase inhibitor, exhibited a radiosensitizing effect in the preclinical models, and therefore, in patients with non-small cell harboring EGFR mutation, gefitinib monotherapy overwhelmed chemotherapy, and there was an evidence for that, and that led to the idea for this trial that chemotherapy could be replaced by gefitinib. It was an open-label, multi-institutional, single-arm phase 2 trial, and the patients included were chemotherapy naive with an exon 19 deletion or an exon 21 L858R point mutation. Patients were treated with gefitinib, 250 milligram per day for 2 years, plus concurrent thoracic radiation, 64 gray 32 fractions, to assess the efficacy, chest and upper abdominal CT every 2 months during the first 6 months and at least every 6 months thereafter. Additionally, full staging chest and upper abdominal CT, brain MRI, PET CT were mandatory at first 1 and 2 years. The primary endpoint was PFS at 2 years. So patients flow in the study, 28 patients were registered, 1 patient was excluded because of the inadequate informed consent. Therefore, 27 patients finished the study treatment, 21 patients discontinued, 12 due to adverse, even 7 due to disease progression and 2 due to patient's will. So only 6 patients completed the entire treatment. The baseline patients' characteristics were the median age was 67 years. With an unequal ratio, the female gender was more. The ECOG was evenly balanced. The ECOG was sort of 0 and 1 were taken. The histology was exclusively adenocarcinoma, with the median follow-up was 51.8 months. The results: the PFS rate at 2 years was 29.6%. It was a one-sided confidence interval. Median PFS was 18.6 months. PFS rate at 1 year was 66.7%. PFS rate at 2 years was 33.3%. Subset analysis did not reveal any difference among the gender, smoking history, type of EGFR mutation, and the clinical stage. The tumor shrinkage only showed a complete response in 3 patients with a partial response in 19 patients. The overall response rate was 81.5%, and the overall survival was 61.1 months. The Kaplan-Meier showing the overall survival, the PFS and the overall survival. Adverse events, not too many. The skin reactions, or all more so, in except for the increased enzymes, none whatsoever clinically as such. The treatment exposure, patients did develop pneumonitis, 8 patients. There was a disease progression as well, which was in the brain. I'll tell that later. Grade 4 adverse events were 3. patients will not to take further treatment. And gefitinib was given for a median days of 332 with a range of 26 days to 736 days, and dose reduction was also there. Thoracic radiotherapy was 62.9, the range being from 38 gray to 64 gray. The V20 lung, it was 26.5 gray with a range from 14 to 35 gray. Site of initial relapse, within the radiation field, there was only sort of one relapse in the primary site and one at the lymph node. The brain only showed 12 extra thoracic sites. Post-study treatment, patient underwent a second-line erlotinib with subsequent therapies. One patient underwent a checkpoint inhibitor treatment and one with immune checkpoint inhibitor. They were also given cytotoxic chemotherapies, third line, and stereotactic radiation was done for the brain survival, brain metastasis. I'm sorry. Pardon. So the important findings are that, as revealed in the preclinical study, EGFR TKI plus revealed its activity. Very few relapses within the radiation field. Substantial proportion of patients relapse with the solitary brain mets. Most of them received stereotactic radiotherapy at the time of progression, and their OS was significantly better, suggesting the importance of managing brain metastasis. To overcome this study was prior, so a newer thought was concerning the osimertinib, which has a better brain or a CNS penetration, but there was also a concern with regards to the pneumonitis, which osimertinib has a higher rate with the thoracic radiotherapy. So brain metastasis and other metastasis of the brain metastasis tend to do better with the role of or with the help of stereotactic radiotherapy. Limitations: it was a single arm trial, cannot eliminate the selection bias, small number of participants, efficacy outcomes had wide confidence intervals. Nevertheless, the PFS result is still valuable. Needed 5 years to enroll a significant number of patients, as it is uncommon to investigate EGFR mutations at this time of the study. This could have been affected by application of a newer agent, namely immune checkpoint inhibitor, osimertinib. However, this population was typically insensitive to ICS, and only 2 patients received osimertinib. This prospective study revealed the tolerability and the possible efficacy of gefitinib plus concurrent TRT in patients with locally advanced NSCLC having an EGFR mutation. Thank you.
Thanks, Dr. Pranav. Only 6 completed the treatment.
Only 6, sir. It was I don't know, sir. It was only a 6 patient that had completed the study. Yes,
but
sir.
they have given a lot of important data, this, that, and all. You feel
Yes,
it's really worth it to take this data further? Because number completed is very small, I feel. Even though we expect a lot, like cetuximab in head and neck, something
Yes,
fit in, but if it comes, it will be really worthwhile. But somehow I feel that there is, but maybe it is the reason that the organizers, we wanted to bring it out to the audience. Yes, there's a study like that.
yes.
Thank you,
And
Dr. Pranav.
thank you, sir.
Any other points you want to mention on this?
So it was more of a concurrent as well as adjuvant gefitinib, which was going on for 2 years. The study was planned in such a way. The rationale of using gefitinib for such a long time, no rationale was given by the authors in the paper.
Thank you. Thanks a lot.
Thank you, sir.